Good afternoon, everyone, and thank you so much for joining us. This is Tracy Morton at the National Rural Health Resource Center, and we're so happy that you were able to join today for our interesting webinar about health information technology. Today, we're really pleased to have joining us Joe Wyboda, and he's going to be talking to us about cybersecurity threats in rural America. First, I'll tell you a little bit about Joe and what to expect from the webinar today. So Joe is the Chief Information Officer here at the National Rural Health Resource Center, and he also is a health information technology consultant with Rural Health Innovations. Joe's been working in information technology and health information technology for about 25 years. He has extensive experience with rural hospitals and rural clinics throughout the country. Did an enormous amount of work with Minnesota and North Dakota hospitals and clinics when our organization was serving as a group effort on meaningful use with the regional extension centers. Joe is an expert in privacy and security information, which is what he'll be talking with us about today, and has served as a CIO as well and an IT manager and director at other organizations that were working on healthcare issues too. Today on the webinar, I think it's a great opportunity for us in the State Flex program to learn a little bit more about what cybersecurity is, and then be able to translate that via this webinar content to what it means to the critical access hospitals who are certainly facing this threat. And if they don't have IT staff of their own, or this maybe is a new concept to them, they might not know what to do. So Joe's going to provide an overview today of what this cybersecurity is, what critical access hospitals need to be thinking about, and some actions that they can take to prepare themselves. Thanks so much for joining us, Joe.
Thanks, Tracy, and great to be here again. It's been a while. Excuse me, it's been a while since I've done a presentation for you folks, so I'm glad to be back. This is a real timely topic. If you've been watching the news, just the other day we had a pretty significant data breach at Yahoo that happened years ago. It didn't happen last week. It happened years ago, and they're just catching it now, which has been a common kind of theme, that we're seeing these massive data breaches where we find out about them much later. I'm going to kind of make the case today about how we can protect ourselves, what we need to be aware of, what the critical access hospitals can do about this, and I really see this year as kind of the blossoming of ransomware, and watching the news, there have been so many stories just about weekly of hospitals that are either paying the ransom or choosing not to pay the ransom to get access to their data. And oftentimes they are small hospitals that you're hearing about. So I'll talk a little bit about how this threat has kind of evolved, where it comes from, how you can protect yourself, and what advice you can give to those critical access hospitals in your state. I work at the National Rural Health Resource Center, and as you know, we're your technical assistance provider. So why is this important? If you're not familiar with the Office of Civil Rights website, it's kind of interesting. You can see all of the data breaches for 500 or more patient records that have occurred, and I pull that report down every now and then and do a quick Excel spreadsheet on it to see how we're doing as an industry, and we continue to do horribly as an industry. Since the data has been collected, which I think is 2009, 168 million patient names have been reported to have been breached. I highlight the word reported because these are only the ones that people self-report to, or that are required to report to the Office of Civil Rights. If you have less than 500 patients breached, you can technically choose not to report, and so I wonder how many more have actually been breached. When you look at the reason or the type of breach, 126 million of those breaches are reported as having either a hacking or an IT issue being one of the factors. That's as deep as I can get into the data. There isn't anything that says this was due to a virus or due to somebody losing a backup tape. We really don't know, but the vast majority of the data breaches are due to IT. There are categories in there where they can select there are paper records that were lost, and those are just not as prevalent as the IT ones. It's a lot easier to lose or to breach 20,000 patient records electronically than it is on paper, right? 20,000 patient charts is a lot of paper. 20,000 patient charts electronically, is a memory stick. It's pretty simple. And one thing that we should really be aware of, and I don't think a lot of the critical access hospital leaders or IT folks really understand the value of medical records. In the dark web, the black market, credit card numbers are trading for anywhere from 25 cents to $5. Social Security number is about 20 bucks, but a medical record, which can be used to create what they call FOLs, a complete dossier on a person that now you can kind of do anything you want with that person in terms of stealing their identity. A medical record is trading from $100 to $1,300, depending on the depth of the data. So there's a lot of incentive for folks to go after medical records and to try to hack into organizations. So far, that has not been the primary motivator as far as we've seen. And the simpler way is just to do ransomware, and I'll talk quite a bit more about that in a second. So today, I just wanted to paint the picture there. My job is not to try to frighten you. I don't like those kind of scare tactics, so I hope you didn't take it that way. But my job today, we're going to talk about the types of cyber threats that exist, not just ransomware, but the whole spectrum that's out there. Review some of the mechanisms that malware commonly used to infect computers. Discuss the consequences of a malware attack. And malware is kind of the broad term for malicious software. We're going to present some steps that critical access hospitals can take to reduce the risk. And hopefully these will make sense and be real common sense based on some best practices in IT. Discuss how to respond to a malware incident, and that's a really important thing that a lot of healthcare organizations are not really prepared to do properly. And then I will spend some time giving an example and talking about this really burgeoning threat of ransomware, and it is kind of a unique threat. And I attended a CMS webinar a couple of weeks ago where this was really the topic, and CMS recently came out with a fact sheet on ransomware just for HIPAA, and I'll refer to that later. So you'll see that in malware, the language that's used is really based on medicine. So we talk about threat landscape, we talk about infection vectors, infected computers, a lot of that stuff. Sometimes people will think that malware, like a computer virus, is something that evolves in the world. That's not true. A virus is something that is written by somebody, and it's something that is modified by somebody from a previous virus, perhaps, to spread. So a virus is something, and that's just one type of malware that infects files and seeks to replicate itself. Compare that to a worm, which is really a standalone piece of software that replicates itself. So you can think of a virus as something that might infect certain executable files, or it might infect your web browser, for example, as opposed to a worm, which is something that keeps copying itself until it gets spread to other computers. A Trojan horse, if you're familiar with the old story, is something where it misleads users of its true intent. These are one of the most common vectors, where you are downloading something that purports to be a free antivirus software or a free something, and actually a malicious piece of software. Incredibly common. Spyware is something that's also pretty common. We've been able to control it pretty well. But spyware is something that really tracks without your knowledge what you're doing, and it's related pretty closely to adware, which is the next one, which is software that delivers advertising, usually unwanted. So there's been a lot of argument whether adware is malicious or not. The fact that adware usually installs itself without really making its purpose clear to the end user. Most people consider adware to be malicious. Adware really looks at your activities, what you're doing, and tries to present ads to you usually in your browser, in your web browser, that are tailored based on what you've been looking at on the internet, what you do for a living or whatever. As you can imagine, adware is one of those things that can be modified to be more malicious than just delivering ads. Scareware is kind of an interesting one that you don't hear the term very often, but this is the website where you go to a website and a pop-up screen comes up saying that your computer is infected and you have to remove the virus, and it gives you a button that says remove. That's almost never a real thing. It's something to try to scare you into doing something, and then something happens to your computer. It might install adware. It might install ransomware. There are a whole host of things that can occur with scareware. It's almost more of a vector than anything else. And then ransomware, which is the one that seems to get in the news a lot. This is software that intentionally holds your data hostage. It goes out and it searches for data, specific types of data usually, encrypts that data in a way that you really won't be able to get that data back without the password, which is now for sale to you in a format called Bitcoin, where you get to pay thousands upon thousands of dollars to get your data back, depending on what your situation is. Sometimes it's $50 for a personal computer. Sometimes it's $75,000 for a critical access hospital. We just had one last week that was reported. That was $75,000, and the hospital chose not to pay the ransom. Those are kind of the threats that we have today. And what's interesting about these, when viruses and worms first came out, there was a lot of ingenious work that was being done by people that maybe didn't have a job or were looking for ways to make themselves famous in certain circles and writing some pretty interesting code that was malicious. Now what we're seeing is a lot of these are developed based on kits that are available for download on the dark web. So it's like it's been weaponized, and you can download this stuff and modify it for your needs to be able to deliver whatever you want. The good news about that is it makes it a little easier for antivirus programs to stop it. The bad news is that code is now out there, and it's what we call in the wild, where people can go and modify it and create their own weapon. CryptoLocker is a great example of that. That's one of the most common ransomware tools out there. So how do these things go around? How do they spread? And I use the term infection mechanism, and in antivirus circles it's called an infection vector, just like it would be in the Centers for Disease Control. If you remember back in the 80s or 90s, I'm old, and I remember where you'd go to the library and get some software to use for your computer, and it would come on a floppy, and oftentimes that floppy would have a virus on it. Infections can still be spread that way, although it's not very common anymore for an infection to be spread from a USB drive. Just about everybody protected themselves from this, and so that is just not a very common way to spread viruses. But that was the common way up until probably the last 15 years. And then spreading via the network is what a worm typically does. But now, we're seeing just about every virus do that some way or another. And this comes from having your local network essentially being wide open, that anybody can do anything within the network, and the virus will rely on a flaw in a service that's provided on your computer, or an open port on your computer, as they call it. The NIMDA worm was famous for this, that it exploited some openings on Microsoft Windows to spread itself around a local area network pretty quickly. Email is one of the more common ones, and this is where we've kind of done this to ourselves by allowing HTML emails and attachments that can carry these things. So one of the most common attachments that's sent out in email is .doc, a Word document, and those were carrying viruses pretty commonly, that people were able to insert viruses simply into a Word document, particularly with macros. We saw a lot of macro viruses for a long time. Those have really decreased because a lot of Word your Word program is set to look for macros and warn you that they're in there. So that has not been as common. The zip file is still a very common mechanism, and you'll see the occasional emails that you'll get that will say, please pay this invoice immediately, and you don't know who it came from, and it's got a document that says invoice.doc.zip, and then you double click on it, and you might get infected once you open the file that's within that zip file. So that's still there. Now, the big thing is web browsers, and using social engineering to look at what your habits are in terms of what data is stored within your web browser and within the cookies to target you for a specific type of attack. So if you are interested in guitars, for example, you've been shopping at Guitar Center online, maybe it will say special deal on Gibson Les Pauls, and you click on that, and it could infect your computer. Or using scareware, something that says your computer is infected, click here. Most of these rely on flaws within the browser design, in browsers that are older, and that's kind of the vector for those. But that's one of the reasons that we really tell people that you have to keep your browsers up to date because of all those openings. So there's some of the ways that viruses, malware can spread, and you heard me talk a lot about how what the email might look like. For example, just by opening an email, you really can't catch a computer virus or any malware by simply opening the email. You have to be convinced to click on an attachment usually. So there's a end user education here that can eliminate a lot of the malware that we're seeing today, and I'm going to talk about that in a little bit too. So let's go through an example. This is one of the ways that ransomware can actually get installed in your computer, and I'm going to show you a screenshot from Microsoft of one piece of ransomware. So you go and you search for information or maybe some software in Google, like we often do, and of the sites listed, you select one that has been compromised, and maybe you think you're downloading a piece of software that you need, but and maybe it has a legitimate looking error message, like I'll show you on the next page. Once you click on the OK, your files now start to be encrypted. And this is an example of one right from Microsoft that if you're familiar with the Microsoft blue screen of death, which we used to see a lot more in the Windows XP days, it would look just like this. And it wouldn't say BSOD, which stands for blue screen of death, but it looks similar to this. So you can see here that there's a number to call, Microsoft technicians. It's a toll-free number. You call that number, and you get to pay a fee if you try to go through that. They'll tell you your computers are locked up. You have to pay $500 or whatever it might be. And there are a lot of examples of this. This is just one simple example that we've seen. I've seen this one personally a few years ago. Not on my computer. I was a good boy. I've never gotten caught, but I've seen this one before, and they're really out there. And the scary part about it is that your antivirus software probably will not catch most of these. It relies on people to be uninformed and a little bit gullible to click on the right button. So what are the consequences of this? If if your network, if your computers, if your servers at a critical access hospital are compromised, or at least there's malware on them, patient care processes can be disrupted. And that can mean patient safety concern, right? I've known of hospitals that have had to go on divert, where they'll just keep the ER open and everybody else gets transferred, just because of this. Really, there's no reason for that. I think one of the points I'm going to make is that every hospital needs to have solid paper backup processes in case they do have downtime, because downtime is something that's going to happen. But oftentimes, hospitals really are not prepared for that level of downtime, where you have to manage billing, patient care, lab tests and results. I mean, the whole thing. It can be very disruptive. Same thing with the business processes. Many organizations have had months and months worth of backlog bills that, due to a virus attack that knocks out their computers for a week, it can still mean that they have months where they're behind just trying to get caught up. Because we've automated the billing process in a critical access hospital and most hospitals really well. That means that when we do have it, we don't have access to it. That is just going to cause more workload. But a big thing is reputation damage. Even if there's not a reportable breach, word gets out pretty quickly that the hospital has a computer virus. Registration says, I'm sorry it's taking so long, we have a computer virus and it's holding us up. That can damage your reputation. But then when you take into account that there's, the requirement if there's a patient data breach of more than 500 patient names, that you have to notify, the Office of Civil Rights and local media and those patients. That's a really stout blow to your reputation. That's something that you don't want to have happen. And like I said, every week in the news there's a different ransomware attack, and the hospital is named every time. Probably a big concern is that patient data loss. I mentioned earlier the value of a patient medical chart and what that's worth to somebody in the dark web for identity theft. That is just a very rich data set to work with. Not just for having them, their health insurance information, so that maybe now they can get some free medical care, but oftentimes Social Security numbers are in that information. Certainly demographic information that can be used to put together a driver's license. There's just a whole host of things that can be used for. And these financial losses for patients can be, something that the critical access hospitals is going to have to cover and protect them against. So there are quite a few consequences that are negative about this that we have to make sure that we're aware of. So one of the discussions that we have is how do we know when a breach has occurred? And the way I mentioned on the next couple of pages a fact sheet that CMS put together is very nice about discussing ransomware in particular. But they really stress the point that any malware event is considered a security incident and requires an incident response. The HIPAA regulations have really a few prescriptive things in them, and one of them is that you have to have a security incident response team. That's a really good thing. It's not an onerous regulation. This is a good one that really can protect an organization. We have one at the center that if there's ever any security incidents, we meet quickly and discuss and determine the level of risk if there is. So that incident response team has to determine the likelihood of whether PHI, protected health information, was acquired by the attacker. And CMS has said that if protected health information is encrypted, we have to assume that data was acquired. So you can imagine that a critical access hospital is pretty likely to have, on the order of 100,000 patient names in their database. Folks that are deceased, folks that have come through traveling, whatever it might be. It's not uncommon to see that many patient names in the database. If that database is encrypted, that means that a breach has occurred where the data was acquired, all 100,000 patient names. That's a lot of people to protect with insurance and so forth. That's really a significant data breach, right? So that was pretty controversial when it came out. That some people said, the attackers are not looking at the data. We don't have evidence that they downloaded it. CMS, the Office of Civil Rights, came out and said, no, if it's encrypted, that means the data has been acquired. We have to assume it's a breach. And that incident response and that investigation is really key to this whole process. And to be honest with you, as an IT professional, we in IT have been terrible about putting together incident response teams, that we try to handle it internally. That really is not the way to go when it comes to a malware event. That we have to have a team that includes leadership and others to help determine what the right path to go is, and to ask those tough questions about whether data was breached. It's pretty likely that it will require third-party experts, whether that's a local consultant or somebody to talk to, particularly in a more significant breach. So what should critical access hospitals do? I already mentioned that HIPAA has some great policies in it that can make a difference, that put in some kind of best practices for IT management. One of those is the annual risk assessment. HIPAA doesn't say it's annual, but they say periodic. It really should be annual. Meaningful Use says it's annual, at least to review it. So that risk assessment is key, because you use that as an opportunity to really review how well your organization is protected, what the risks are, and what percentage of likelihood you have. And there are some really great tools for risk assessment that we use and we can share with you as well. The incident response policy and procedure is another one that has to be taken very seriously. In the event of a malware attack, that incident response is incredibly helpful, and it keeps you focused. There are also requirements within HIPAA for system monitoring, and that's where, and when I've done privacy and security risk assessments for hospitals, I get a lot of pushback on this, and I really don't understand why. I mean, I guess I do understand, because it does take some time, and it has to be part of the practice. But for the IT professionals to go in and review the logs on their servers periodically, looking for any suspicious activity, repeated login attempts, whatever it might be, just looking for any suspicious activity, it's a best practice. And it's something that HIPAA really wants you to have a policy and procedure on when you look at it. That is a required element. And I can't stress backups enough. Everybody says they have backups, but oftentimes they've never been verified. They've never done a practice restore. And that is really key. You don't have a backup unless you know that that you can do the restore. I worked at one organization where they had accidentally deleted some data, and that's when they found out that their backups were doing absolutely nothing, that they had no backups. Thankfully, it was a reasonable amount of data. It wasn't protected health information, that they were able to make do without it, but they did lose quite a bit of data. So it's important that the backups be verified. Off-site storage for backups is important, but we have to remind folks that Office of Civil Rights has also determined that if you lose a backup tape or a backup disk, and that data is not encrypted, that is also a data breach. We have to assume that that data has been acquired. So imagine that if you lose a disk drive that has a complete backup of your electronic health record, that is considered a data breach of every patient you have in your database. And that actually constitutes most of the large data breaches right now are from backups being lost, from what I can tell. So backups are important. Other steps are, of course, they need to install and maintain good anti-malware software and manage it. Sometimes a critical access hospital will buy the license with the computer and they won't be centrally managed. So then what you end up having are some computers that might have an error in their software that's not getting, that's preventing them from getting the most current antivirus definitions, and you don't know that until the virus hits. So it's important to, if possible, manage them centrally. And that should include the servers as well. Electronic health record vendors used to push back on this and say they don't want antivirus in the server. They've really loosened that up now, just because of all the attacks that have occurred. And if the electronic health record vendor does not allow that, they need to put that in writing and you know, find a way. You have to really pressure them to allow antivirus in the server, because we're seeing too many virus attacks on servers now. Keeping things up to date, sound firewall practices, those are really important things, and these are all really fundamental IT responsibilities, but they're oftentimes a luxury for small IT departments. They really don't have the time. And when you think about a critical access hospital, I've worked at hospitals where their average daily census is on the order of 1, and they might have a person come in for 4 hours every other day. And that person is taking care of maybe 100 computers, you know, for 4 hours every other day. It's really hard to keep up with things like that. And they're probably not a firewall expert, and they're probably don't have the time to, you know, implement a centralized, you know, antivirus package. So critical access hospitals, all small providers like that, really need to look for good solutions for, you know, having consulting and outsourcing assist with that, particularly with firewall. It's rare that you'll see a small organization, I don't care if it's a critical access hospital or not, that really has the expertise for good firewall protections. And that's something that I routinely will probe when somebody asks me to do a privacy and security assessment at their organization. Probing that firewall, you find out that there are a lot of openings that can be exploited by viruses or worms, but by malicious hackers that really want to try and get a login into the system. So they really need to, and these things can be outsourced to places that don't have to be local. They can be far away and can be fairly reasonably priced. I also, you know, mentioned that good downtime procedures and testing them is really key. And this is not something that is IT's responsibility. This is the organization's responsibility. It's not if, it's when you're going to have downtime. There's always going to be something that can fail that will mean that you'll have significant downtime. And when I say significant, more than, you know, a couple of hours. We've had, you know, we've read about hospitals that have been down for weeks on end as they do a restore. Depending on how your data is backed up, restores can take quite a bit of time. And having those good downtime procedures can be the difference between, you know, patient safety and financial well-being. And then training staff on smart browsing. HIPAA does require that you talk to staff periodically, do periodic training on privacy and security. It's a great opportunity to talk to folks about smart browsing, about not believing every box that pops up and tells you that you have an error, not clicking on things that in emails that from people you don't know, things like that. And it is difficult for a critical access hospital. It's easy for me to say that you have to do these things, but it is just very difficult to do in practice. Think about a critical access hospital. They have incredibly complex IT systems. If you go to a manufacturing organization and you look at the IT systems they have, they'll have perhaps a materials system that manages some of their inventory and some of their supply. They'll have a specialized system that might run some of their manufacturing. They'll have a financial system. And then think about a critical access hospital, what they have. Because a lab system is more complex than all those things mentioned, for example, just the lab system. And then they have probably a materials management portion of their EHR. They probably have the clinical documentation piece. They might even have a cash register program for the cafeteria that has credit card numbers stored in it. There's a lot of complexity there. And then they have a number of computers between 50 and 200, which every other industry says that something on the order of 50 computers usually means one IT support person. And we're lucky to have one for 200 or 300 computers. So very complex systems where you're relying on vendors, a lot of computers with a limited amount of staff. It really means a massive vulnerability to malware. And then when you put on top of that the value of charts, it really can be a little frightening. So they have to rely on quality third-party vendors, particularly for antivirus, but also consider backups, firewall, and basic PC management. There are organizations that can help with managing the kind of frontline problems with the computer, which include a virus attack and notification that a virus has happened. And they, it's not free. It's something that you have to pay for, but it's going to become something that they'll all have to figure out a better way to do, because it's if the right computer gets infected with ransomware, it can lock up a lot of charts, and the next thing you know, you're having to deal with it. So how to react to a cyber event? It's really important that you identify that there was an event. And like I mentioned with the Yahoo data breach and others that have happened lately, they didn't know about them for quite some time, years. So this is where system monitoring and notifications from antivirus software come in first and foremost. Many firewalls can be configured to give you notifications of suspicious activity, and that's important. But again, that's something that you'll likely need a third-party vendor to help with at a critical access hospital. And end-user notification is probably the canary in the coal mine, where an end user says, I got this really strange email, or I got this really weird pop-up today, and it didn't look right, so I didn't click on it. Can you tell me what this is? Which means training again. Assemble that right team quickly. We talked about that a minute ago when I mentioned the incident response team, and finding the right outside expertise that you should kind of have at your fingertips, somebody who knows your network. Figure out ways to stop the propagation. That can include shutting your network off or disconnecting the internet, for example. Determining whether PHI was acquired is going to be very important. How many records, what specific information. So if there was a data breach that you're convinced involved PHI, you really don't have a lot of time to figure out how many patient records were acquired. And that's why it's so important to gather as much information and preserve it as quickly as possible, log files and backups, and especially log files, because those will roll over and get cleared out. Some malware will go out of its way to clear out log files. There may not be information in there for you, but it's important to capture as much information as you can. For example, if it's a server that's been compromised, then one of the first steps is just to disconnect it from the network and kind of create what they call an air gap, something where nothing further can happen to that computer unless somebody's sitting at it. And then in the event of ransomware, OCR really does recommend that you contact them and the FBI as soon as possible. So if protected health information is being held for ransom, local law enforcement, FBI, and the Office of Civil Rights really recommends that that all three of them be contacted. The OCR has really been plain spoken about this, that if you get them involved up front, they're going to be much more understanding, as opposed to if you try to keep it quiet and then in the last minute notify them right before the right when the 30 days is up, when you should notify them. For example, there was a behavioral health organization that was running Windows XP, which is a out-of-date operating system, and you really are not supposed to use it anymore. They knew they weren't supposed to use it. Their vendor told them they had to get off. They ended up having a data breach of several thousand patients, which they kept quiet for several months, and eventually OCR, was notified. They got a really significant fine that I believe put them out of business. When you look at the data log or the reporting logs that OCR maintains, those organizations that notified and there's rich data inside of there, they got assistance. They didn't get fined. So that's important. I do recommend this CMS fact sheet. It's very good on ransomware and HIPAA. There's some great information in there. It's kind of structured like a frequently asked question list with a little bit more depth. So I think it's 4 pages long. Really an excellent read. I always get the question, should people pay or not? And that's a really good question. If you get the ransomware, your data is held hostage. Once it's been encrypted, if it's protected health information, you're still required to follow the breach notification rule, no matter if you pay or not. So paying is not going to get you out of it. We've seen where we've heard of where you pay and it's still your data doesn't come back. You get some of it back and then they want more money. So it really does involve this calculus of determining what is the cost of restoring all your data versus the cost of the ransom. And in some cases, the payment is much less than the cost of lost revenue or patient safety concern, because restoring files can take quite some time. So this is where discussions with your vendor, getting Office of Civil Rights involved, local law enforcement, can really help you make that decision. And this is one that we talk about in IT a lot, whether or not we pay or wouldn't. And there's probably no simple answer to it. It's not like a traditional hostage situation where you might get a glimpse at the ransom people, because you pay them in an untraceable currency called Bitcoin. There's really no way to figure out who they are, probably. So to summarize, I think malware is going to continue to be a threat. We're seeing how it just continues to evolve. And in the open source world that we live, it gives malicious operators, they have a lot of opportunity to look at code and modify it and create it for their own purposes. Protecting your facility requires more than good antivirus software. When I ask folks about their malware strategy, they all talk about antivirus. It's much more than that now. So, you know, it involves good firewalling. It involves, you know, strong maintenance of servers and PCs too. Like I said, good, well-tested backups, antivirus software, firewalls, system monitoring. Those are going to be critical things that critical access hospitals, in particular, have to really look at. And when you have an IT person at that cause that is, you know, really struggling just to keep up with the demand of kind of first level help desk support, it's a very tricky thing. It's going to be hard to do it with, you know, half of FTE. It's going to take some time. End user training can really prevent a lot of malware from spreading, and talking to folks about what, you know, which emails they should not open and which websites they should not click. I mentioned cause will likely need outside help, outside vendors, and they don't need to be local. That's the good news. It doesn't have to be somebody that's you know, in the town, because there probably isn't anybody, or that's the person who comes 4 hours every other day. It can be somebody from a city further away. So with that, I left a little bit of time for questions or comments or anything. Does anybody have a question or comment? Don't forget to do *2 to unmute your phone, but maybe nobody has a question. If I can put in another plug, it is National Health IT Week, so hooray. And the Office of the National Coordinator came out with an HIT, not a roadmap. Oh no, I'm drawing a little bit of a blank. It came up with an HIT tool today that I'm pretty impressed with. Actually, they came out with it yesterday, and I'll try and figure out what the name of it is in the next couple of minutes if nobody has a question.
Health IT Playbook.
Thank you, HIT Playbook. Health IT Playbook. Google that and take a look at it, because it is really, really very good. I discovered about 5 tools within that tool that I didn't know existed. So I encourage you to look for the Health IT Playbook. You'll see that that the first link actually doesn't work, so you have to go to the second one, and they'll probably fix that soon. I found some tools in there on antivirus as well, so I encourage you to go look for that HIT Playbook and enjoy Health IT Week. You can follow me on Twitter this week as Wyvoda Rural. I'll be tweeting on HIT stuff and blogging as well.
I have another plug too. If this is a topic, health information technology, that's of particular interest to you when you're working in rural healthcare, feel free to join the National Rural HIT Coalition. The coalition is something that we at the Center through the FLEX program put together in 2006 to try to get ahead of the curve of what is adoption of health information technology in rural America going to mean, knowing that it's going to be a little bit different. And so if you're interested in joining the coalition, we have periodic calls. I'd say they're about quarterly. We meet annually once in person to discuss issues a little bit further. We talk about regulations, policies, implications, all sorts of cool new tools and things like that. So if you're interested in joining the coalition, you can send an email to Joe, because it's there accessible on the screen, or you can email Nicole Clement, and we'll get you added into that email list. And then we'd love to have your participation.
I saw somebody was typing, Jill. No. Let's see. Yeah, you know, Jill, that's a great question. I've always thought that there has to be a way that folks could share this, and I know that there are some networks. I think of in Kentucky, the Nikki Rio does some of this. That they have, and they're working mostly with FQHCs and rural health clinics, if I recall. But the same concept will work with critical access hospitals, that they could, in a state, you know, or at least in a region, share somebody like that. I think that would be a really interesting concept. I think that's a really good idea. I don't see why we couldn't do that. Why that couldn't happen, especially if I don't know who would own that person, who they would be working for. That's kind of one question. If you didn't have a network, you'd have to figure out who would hire that person, and then everybody else would probably have to have a business associate agreement with that person or with that organization. But I think that's a great way to do it. I'd like to see more of that. I don't see enough of that, because the security folks are really hard to find. The ones who really know what they're doing. That's a tricky skill set to find, and they're in short supply. One of your causes was asking for it. Where would we start? Good question. I think, you know, finding where that person would work would be my first question. You know, is designing how that would work. And Jill, maybe you and I could brainstorm it. But where I've seen this work within networks, where there's an executive director and they have the members of the network fund it. I don't know how, you know, how it would work for a state like critical access hospital organization to do it. But you know, I'd love to brainstorm that a little bit with you. I'm not sure where that person would reside, unless there'd be one, you know, if you could find a way that one of the critical access hospitals could hire the person and everybody else chips in for a share of the time. Yeah, an ACO is a good example of kind of a network that could do that. And when you think about what ACOs need to do, they need to share information amongst each other, right? They need to share clinical information amongst each other to really make a difference. Sharing information requires that you have a certain level of trust and security amongst each other. So an ACO would be a really great way to centralize that security person. Good point.